I primarily have spent the last 30 years treating adults. And how many of you have even heard of the STEPS programs? Okay, well, that's somewhat heartening because it appears that it's well known in some parts of the U.S., but actually heavily used in other countries. But hopefully this afternoon, there will be this interest in two new models, actually, two new manuals that have been released. And both of them are a collaboration with the National Health Service partnership, the Sussex Partnership in the UK. And so as you can see that we had several collaborators here, and we were originally funded by NIMH, and in the interest of disclosures, as well as a thank you to an incredible team that I've had the privilege of working with since 2002. In terms of where it has gone and is used, you can just see a quick thing, but it originated here at the University of Iowa, which is actually the country's largest public teaching hospital, despite the fact that many people on the coast are imagining a big red barn. Our newest publication, edited by Dr. Don Black and myself, describes how the STEPS program has been implemented in various countries and with different populations, including adolescents. And just a very quick review of the STEPS program as developed for adults and now modified for adolescents is that it is a group treatment program and it is a psychoeducational approach. It is manual driven. The first part of the manual contains lesson plans for the 20 weeks of the adult program, and the second half contains the weekly lessons that are then printed out and given to patients. It is a cognitive behavioral model plus skills training in specific emotion regulation and behavioral skills. One of the unifying concepts, thanks to Jeff Young's work and giving us permission to modify his schema questionnaire, is to tie the early maladaptive schemas to the actual criteria and to the emotions and behaviors. It includes psychoeducation for what we call the reinforcement team, all those people, whether it's family members, professional caregivers, community support people with whom the patient with BPD shares information about their disorder, as well as teaching more effective ways to respond. And we'll see how that is fleshed out in the adolescent model. Perhaps the most, I think in some ways, if I had to say what is the most important aspect, and I think it is that it teaches a common language for people with BPD and those in their system to communicate about the disorder. I have always said that I think the virtue of working in a field that has a multidisciplinary approach that's a strength, but I think it also, in many cases, is a hazard because each of our disciplines has a different language. And when I have dealt with patients whose brains are in a state of chaos from anxiety or whatever intense emotion, they tend to go from one part of the system to another, and while everyone in the system may be giving them essentially the same message, because they are hearing different words, it's often for them, they believe they're getting different messages, and so whatever your capacity is, when you respond, their response is often, oh, but my psychiatrist said, but oh, my social worker said, but oh, my case manager said, but my voc rehab, person said. And then we talk about these people are always splitting the treatment team and being so manipulative. It was designed as a treatment to be done in the outpatient clinic. People come, learn a skill, part of a skill, take it back to the natural environment to practice it. However, we are finding that parts of it can be introduced during a short inpatient stay. Also, we use it in our partial hospital program. Day treatment programs are using it. Residential treatment. Assertive community treatment often involves making sure the person gets connected to a local STEPS group. Here's another use for it, and the setting I never anticipated, but has been very, very responsive, and we've published a couple of papers about our outcomes, and that is in the correction system, both in prisons and in community corrections. And I've spent probably the last 10 years as a consultant for the Iowa Department of Corrections. As I said, it was initially developed for adults, but the new version for adolescents originally uses UK spellings and cultural examples, and just within the last couple of months, I have translated it to American English and examples. The focus, it does not use the term borderline personality disorder. The focus is on managing emotional intensity. It's been divided into 2 9-week sessions with a break, which seems to work better with the school year for adolescents. And the reframe we use for BPD is emotional intensity disorder. In this version, we talk about emotional intensity difficulties. And the study that's described in the book I showed you reports the first 3 UK groups were 16 and 17-year-olds, but I really feel that, it can be expanded to a range of 15 to 19. There are a couple of studies going on, one in Indianapolis at the University of Indiana, one of the outpatient units that are associated, and they are using it with 18 to 24-year-olds, and I think that this is becoming more common, and part of it because of the difficulty of getting IRB approval for adolescent studies. They may still be pre-diagnostic, but some of them may actually have the diagnosis or have heard of it. We do not make an attempt to hide it, but again, to focus on the emotional intensity and the resulting behaviors. The past symposium that I sat in on talked about the importance of involving parents, and in the UK, and we've made the same provision in the US version, is that a concurrent parent group is held at the same time, and parents learn what their adolescents are being taught, and they actually fill out the weekly evaluation forms on how they view their adolescence, not with the idea of making them into therapists, but rather to learn the language. And we also emphasize that the adolescents are the ones to ask for how much help and involvement they want, which of course can vary from week to week. Feedback has been very positive from both groups. I want to just take a minute to talk about another version that has been developed with the UK partners, with the idea of it being used in the primary care system in the UK. And it is a 13-week program for adults who, again, are considered pre-diagnostic, 3 modules, and people can decide after the first module how much further they want to go or whether they want to do all 3. Also the same terminology, and again, some of them may in fact have the diagnosis or heard of it, so it is similar to the young person's version. Currently, there is a grant to research this version, and they are hoping also to get funding for the young person's version. And again, the primary goal is to look at the person as driven by the symptoms to seek relief through behaviors that have been reinforced by negative and distorted thinking, and to express the empathy of how difficult it is to experience intense emotions that feel out of control. As well as acknowledging the pain that people go through, but rather than sort of, focusing as much on the name or necessarily sort of buying the whole package. It is a 3-step program. The first is to become aware of the criteria. Secondly, to learn the 5 skills of emotion management training. And finally, the 8 skills of behavior management training, because we certainly know that emotions and behaviors interact with one another. Kind of the heart and soul is to make the abstract concept of an emotional intensity continuum as concrete as possible. And there are many metaphors that can be used, from weather symbols, as we see, to what has become our preference, but we make all of them available, and that is pots on a burner, because as a patient once pointed out, she has no more control of the weather than she does her emotional intensity, but she can control pots on a burner. Another group came up with a volcano, which probably is also very difficult to predict or control. And the adolescent version, one of the patients added this to our storehouse of Continuum, and we make all of them available through the manual, as well as a blank for them to draw their own. The idea of the emotional intensity continuum, the drawings are not the important thing. It's the awareness of the way emotional intensity develops and the connection between the level of emotional intensity and the resulting behaviors. This is an illustration in the adolescent manual of the cognitive filters or schemas, and we see 2 different people looking at the same situation, and we see a difference in how it is perceived. Finally, how many of you have heard of our measure called the BEST, the Borderline Evaluation of Severity over Time? We have simply changed the name, the criteria that are listed, and the behaviors are the same, but it is the quick evaluation of severity over time and looks at these three areas. Patients put their weekly score on a chart, and they are able to observe the changes, the variability, but over time, that the means come down. There's a little blip there as you get close to the end, in this case, the adult, the 20 weeks, as we started to talk about it ending. However, by the next week, we've acknowledged the abandonment issues and their scores come down. We are always happy to provide you with a copy of the Quest or the Emotional Intensity Continuum. Just simply email me. And finally, the chapter describes the three pilot groups. It is descriptive. There were no controls, quantitative measures, but by the end of the third, in their third group, they did find improvements in the ER visits, hospital days, and crisis incidents. And as I mentioned, the feedback from the young persons and their parents were very positive. I'm going to just flip through that very quickly so that we can go on to the next presenter, since we got a little bit of a late start. I think we'll hold questions until the end, if that will be okay, and I will turn it over to Dana Borkham. Thank you.